We talked about some clinical impacts unique to PFA. Did anyone review coronary artery spasm?
Yes, Dr. Asirvatham highlighted the concerns in PFA ablation.
Dr. Asirvatham, good. He's really an expert. Tell me more.
Coronary artery spasm. So the advent of pulsed field ablation simultaneously took away a lot of problems we faced with day-to-day ablation, particularly because of heat transfer, collateral damage to the esophagus, pulmonary vein stenosis, something we thought about, we taught, and tried to find ways to minimize, has almost gone away with pulsed field ablation. But at the same time, things we didn't think about with radiofrequency ablation, we now need to understand and minimize. These include microbubble formation. These may include discomfort like skeletal muscle discomfort, hemolysis, and coronary artery spasm. So let's go a little bit into some background to understand what we're dealing with in terms of coronary vessels and why spasm should be a thing. Now, with pulsed field ablation, irreversible electroporation, the actual cell disturbance and death are as a result of the electrical field. The electrical field, albeit a pulsed field, is never around one type of tissue alone. We can have multiple tissues all exposed to the same field simultaneously. Now, in most instances, we're dealing with myocardium in the field and non-myocardial tissues like endothelium, the pericardium in some instances, nerves. And myocardium, because of the nature of the action potential and membranes, is uniquely susceptible to pulsed DC ablation. But is it the only myocardial substrate within the field? We know the esophagus has muscle, but good data to show that there are no long-term effects of placing the esophagus in the pulsed DC field. The coronary artery, on the other hand, is a unique structure. Like the pulmonary vein, there is a zone of endothelium and an adventitia or external layers, but almost a hybrid type of middle layer, which is the tunica media. And the tunica media is layered smooth muscle cells with their actin and myosin overriding at an angle to the parallel laying down of these cells that cause constriction, that eventually decrease the lumen and blood flow in the coronary vessel. Now, if we have a field that goes across this structure, there is the possibility and now clear demonstration that spasm of the coronary arteries can occur. Now, contrast this to some of the early work. This is from my colleague, Dr. Elad Maur. Rabbit carotid arteries, you actually electroporated, ablated with pulse fields from inside the artery, and we did not have any permanent loss of architecture. This is a different situation. We're not talking about thermal damage to the artery, but spasm of the actual vascular smooth muscle. In a large artery, the percentage of luminal narrowing that's possible even acutely from spasm is limited. But in the coronary vessels, this becomes a very real issue that needs to be understood, and we need to have a game plan for preventing when we apply pulse field energy somewhere near the artery. So where are these sites? First, pulse field applications in the international experience, when targeting the pulmonary veins or the intervein pulmonary vein tissue, the posterior left atrial wall, have not been associated with clinically recognized vasospasm. But as part of the natural off-label evolution of any technology that we've had as electrophysiologists, there's been applications for the common additional substrate that we use during our AFib ablations. The mitral annulus for perimitral flutters and the tricuspid annulus for cavotricuspid isthmus flutter. And if you notice, we see the pulmonary veins, we see the left atrial ridge, a strip of isthmus-like tissue, and then the mitral annulus. But notice the coronary veins and the nearby coronary arteries are very close to the annulus and not separated by much tissue from endocardial electrodes that could deliver pulsed fields. This results in the arteries coming within the field. Now, I should state that there are several hypotheses to why the arteries go into spasm. These include the electrical field itself stimulating and creating an action potential in the smooth muscle, or partial poration that affects the endocyte cytoplasmic calcium. And this calcium loading gives rise to the spasm. There are also some alternate theories being looked at, like just partial barotrauma or vibration, or microbubbles that may reach the vessel. But data to date is strongly pointing to a direct effect by calcium on the vascular smooth muscle. Now, in the case of the cavotricuspid isthmus, the muscle that separates the annular coronary artery from the actual endocardial electrodes is very small. And let me show that to you using this model. Here, if we look at the tricuspid annulus, the arteries themselves are extremely close to where we would ablate. And the degree to which they are close depends on how thin that myocardium is. So older people, large atria, Epstein's anomaly, we may be actually placing the electrode in pretty close proximity to the vessel itself. When we look at the left atrium, we have a similar issue where, especially as we go more anterior, we get very close proximity to the artery from endocardial ablation. As a result, we are now placing the artery within the electrical field. If this disturbs the calcium homeostasis of the individual cell, then there's calcium loading in the cell, and this can produce contraction and produce spasm. Now, if we look at the calcium in and out of the cell, restoration of homeostasis, it's pretty quick. So you would have guessed this wouldn't be a significant clinical problem, except a very important piece of physiology of the vessels. It's not an equal two-way street. Spasm, when it occurs, is clearly calcium overloading, but removing the calcium out does not reduce the lumen. The spasm stays. In other words, calcium is the on switch for spasm, but the off switch is something else. And that something else is a phosphatase-based system that's much slower. So once spasm occurs, then this may remain long after the electrical field is turned off and the calcium homeostasis has returned to normal. This is a critical piece of physiology the electrophysiologist needs to keep in mind of why we need to prevent spasm before it occurs. First, what would be the manifestations of this spasm? Do we worry about an irreversible ablation of the coronary arteries? The short answer is no. I'll show some data that this can happen, but the large part is actually within the reversible electroporation zone, where we have enough calcium changes, ion flow, the spasm has set in. If we can tie it over without sequelae from the spasm, the artery itself will recover. Now, how do we manage this? The first is, at this point, it really does appear that proximity is important. We have to think about this complication when we are close to the coronary arteries. The mitral isthmus, if and when ablation is done on the roof of the left atrium because of the sinus node artery, the sinuses of Valsalva, if we ever ablate, very likely in future ablation, this may be a limitation with epicardial pulse field ablation and the cavotricuspid isthmus. Now, I should note that there are still many mysteries to why this happens. We consider this a field effect, but at the same time, the myocardial ablation lesions are contact dependent. So that these two are a little bit contradictory. If it is a field effect, then we should have seen field effects in the myocardium regardless of contact, and we don't. And if it is a contact effect, then we would need contact with the vessel, which we don't to get this. So this is an ongoing area of research to try to understand what is the solution to this dilemma. But it's clear it happens, and if it happens, we can get a myocardial infarction, we can get ventricular fibrillation from large coronary vessel spasm. So we need a strategy to prevent it from happening. Now, before I discuss the workflow or method for prevention, just to show you some of our work, my colleague Dr. Ladajobi, that if you actually try to electroporate from inside the coronary artery, like the earlier work with the carotid artery, you can actually get permanent lesions. And the reason for this is probably the thermal effect, that first zone where we get minimal changes in the temperature. On the other hand, if we ablate from near the artery, not on the artery, but near, close to being right on it, but not inside the artery, then we do not see permanent lesions. And this has largely been the experience with other translational studies and the brief human literature. Now, how do we prevent this? First, how does the coronary vessel relax? It's not calcium. It's not the lack of calcium. Calcium is what's going to constrict. But to relax is mainly mediated by nitric oxide. And the main way we get nitric oxide, and we've done it for years for myocardial ischemia, is nitroglycerin. So nitroglycerin has to be given to relax the vascular smooth muscle. Now, does it work when we have calcium overloading? The answer is yes. And we have enough data to unequivocally say that we can reverse PFA-induced spasm using nitroglycerin. But there are a few clinical issues. First, how do we get the nitroglycerin in? We could give it through a peripheral vein, but if the vein is not working, if it's infiltrated, and it's so dangerous to have sustained spasm, we should give it through a central line, preferably in the right atrium itself. And this is fairly easy to do because we usually have sheaths in the vasculature. At the very least, it should be through central venous access. Ideally, and if you're in a high-risk situation, like very close to an artery and maybe future off-label uses in the ventricle or epicardium, we would need to be ready to do angiography to quickly diagnose the spasm and to give intracoronary nitroglycerin if needed. But otherwise, we recognize we may be in a critical location. We should pre-treat with nitroglycerin. And a simple protocol is to use about 3 milligrams as an IV bolus and then use 2 maybe every 2 or 3 minutes after we've actually ablated. So there's some dose that's given before the actual ablation, giving time for circulation, and then continued doses after delivering the energy. Now, nitroglycerin, because it's a potent vasodilator, will drop the blood pressure. And that creates issues because then it will limit the nitroglycerin, and then we could be in a vicious cycle with vasospasm affecting the blood pressure because of loss of stroke volume and our inability to reverse it using nitroglycerin. To avoid that vicious cycle, it's good to give some vasopressin or phenylephrine or some vasopressor type support before we get the blood pressure drop. Now, if the blood pressure is already high, it may be reasonable to keep it ready and use if needed. Otherwise, to pre-treat, get the blood pressure stable, then give the initial nitroglycerin, and then start the ablation. And while the PFA is being done, some form of maintenance, periodic bolusing every few minutes, or some groups will use a nitroglycerin drip during that period. And then once we have ended the lesion, whether we should continue for a while depends on several factors. Now remember that effect on the vessels can be long after the field is delivered because of this calcium-dependent calcium loading that happens in the cells, keeping that spasm until we have enough of the nitric oxide to help with dilation. What are those factors? One, how big an artery is it? Proximal right coronary, left main, a big, large, obtuse marginal in the case of future ventricular ablation. In those cases, the risks are significant to have delayed spasm and be reasonable to continue some nitroglycerin for at least 5 or 10 minutes. Other instances, we saw no change at all. We're not in a proximal vessel. It may be reasonable to stop the nitroglycerin at the time of the last PFA. To summarize, while we have so much in terms of benefits with pulse field ablation over radiofrequency ablation, There are a few potential complications that are much more with PFA than with radiofrequency ablation. We rarely ever saw coronary spasm in all the decades of radiofrequency ablation. With PFA, in the pulmonary veins, we still don't see coronary spasm. But if the electrode gets closer to a significant coronary artery, like the circumflex or right coronary artery with isthmus ablation, then we do see spasm. And studies have shown that even when we don't see ECG evidence of the spasm, there's often angiographic evidence. So pre-treatment makes sense when we're at these locations, and we've discussed a potential regimen to try to minimize the chance that we'll see clinically relevant spasm.
Certainly with PFA, more than RF and cryo, we need to consider the possibility of coronary artery spasm and treat to prevent and minimize its impact when it does occur.
That will be something important for us to review and discuss in more detail for our future PFA cases.